Hi and welcome back. So far in the course we've covered an overall introduction to what is public health, health policy and management, epidemiology and biostatistics, and environmental health. And now we're going to head into the fifth area of public health, social and behavioral influences on health. There are a number of common perceptions that people tend to hold when we think about social and behavioral influences on health, or our health in general. And we saw that when we initially talked about healthcare on a minimum wage and Mary, and we asked about what could Mary do. And there was this idea that most of Mary's health fell to personal responsibility. This idea that we are 100% in control of our health and our health outcomes. And so that tends to look at health this way, right? We tend to view health and health behaviors as primarily being related to our genetics. So we stand on our genetics, and then we have our personal decisions, right? So we have our behaviors, which influence our health. We then adapt to that, we learn from it, we adjust our behaviors. And it's this nice little loop. In other words, if we choose healthy behaviors, right? So healthy diet, alcohol, physical activity, we're going to be healthy. And that's great. But if we choose bad behaviors, alcohol, drugs, tobacco, we have poor health outcomes. And it's all under your control. And so let's look at the 5 leading causes of death in the United States: heart disease, cancer, stroke, chronic lung disease, unintentional injuries. They switch order sometime, but those are generally the 5. And then let's think about what those risk factors are. So I'll give you a minute just to think about what are the leading risk factors for heart disease, for cancer, for stroke, for chronic lung diseases, and unintentional injuries. So the top of the list for most of those things are tobacco use. We can add in things like obesity, diabetes, sedentary lifestyle, diet, alcohol. In some cases, occupational or environmental exposures. We talked about that previously. And then for unintentional injuries or accidents, things like seatbelt noncompliance, alcohol and substance abuse, reckless driving, occupational hazards, stress, and fatigue. And so when we think about the social and behavioral influences on health, these are the things that we tend to think about. And we tend to think about those things as being within our control. And when we look at what the premature contributors to premature mortality are, if we take that pie, and I'll show you the rest of the pie later in a different lecture, but about 40% of that is health behaviors, and that's a pretty good sized chunk. It's the largest chunk out of all of them. And so when we think about that, we tend to think about, well, we have a pretty good amount of control over our health outcomes. Remembering, premature mortality is death before the age of 65. And so when we think about health behaviors, we want to think about, well, why is it that people behave the way they do? Why do young people begin to start smoking? Why do they use spit tobacco? Why are adults who are fully aware of the risks of smoking to continue to do so, right? So a lot of you in your answer to homework assignment 1, when asked about what the employer could do, said, well, the employer can provide education. They can bring in a nutritionist, or they can bring in health educators to teach people how to eat right. And I pushed back on some of my responses in that the question is, most adults know that smoking is unhealthy. Most people don't go to McDonald's and think that they're getting the healthiest food option. So why do they continue to go there? Why do people go to an all-you-can-eat buffet and eat until, they have to unbutton their pants and practically roll out? Why do people throw trash out of their car? We all know that's wrong. Why do we do it? Most people will hopefully brush their teeth in the morning. Not a lot of people floss. One of my favorites: why do some college students repeatedly get so drunk in a single evening that they get sick and not remember anything and pass out, but then go back and do it again? Why do some people exercise and others don't? And so these types of risk factors defy simple environmental control measures, in particular because they involve people's pleasures and rewards, their social relationships and physical needs, and ultimately, for some, their habits and addictions. So they're complex. And so, in order to try to understand why people behave the way they do, we have a number of theories about behavior change. Because we know that behavior change, when done well, can help to reduce risky behaviors. And when we think about that, when we're looking at health promotion and trying to change people's attitudes, we recognize that we have to change behavior at multiple levels. So we have at the individual level factors involving characteristics such as knowledge, attitudes, belief, and personality traits that influence behavior. And so we look at that level using things like the stages of change or the health belief model. We can also target the next level up, interpersonal, right? So interpersonal factors look at the processes and primary groups, including family, friends, and peers, that provide social identity, support, and role definition. And so if we want to target behavior change, we might want to include friends and families and peers that influence how we all behave. And so we would use something called social cognitive theory, which in the past has also been called social learning theory. We might also want to look at the community, right? So community factors are those social networks and norms or standards that exist formally and informally amongst individuals, groups, and organizations. And so if we have a community standard or a norm, and you want to change your individual behavior within that norm, it can be very difficult. And so this is where we might want to use community mobilization, organizational change, and look at diffusion of innovation theory on how do you get a new idea into a community so that it stops being novel and starts to be the norm. One example of this, and I'll come back to it, is the idea of sending in cupcakes for a children's birthday at school. So growing up for me, maybe for several of you, the common thing was it was your birthday and your parents sent in a cupcake. Right? Everybody gets cupcakes or cakes. In my children's school now, that does not exist. They're not allowed to bring in food for multiple reasons. One, it's not terribly healthy to have cupcakes all the time. And the other is that and now more and more we have children who suffer from allergies. So for me, the norm was to have cupcakes on your birthday in school. That's not the norm for my children. And that was a difficult change to take place. But for my kids, they don't know any different, so it doesn't strike them as being abnormal that they're not having cupcakes at school on their birthday. The next level would be institutional. So institutional factors are rules, regulations, policies, and informal structures that may constrain or promote recommended behaviors. And so that's where health policy intersects with health behavior and public policies. So when we want to look at this, let's first look at the health belief model. And so there are two key sub-factors within the health belief model that are used to determine or to try to model health behavior change. The first is perceived susceptibility. Do you think you are at risk for a given outcome? Right? So, do you think the worst might happen? So, if we're talking about, say, a teenage girl who's thinking about having sex for the first time, what is she afraid of? What does she think might happen? What are the risks associated with that? And in addition to whether or not you think you're at risk, what is the perceived severity of those risks? So, susceptibility might be, oops, I might get pregnant. That would be terrible. How bad would it be? What would the long-term impact of that be? How do you internalize and think about that? And so that's going to determine or have an impact on her behavior and what choice she makes. And so together, perceived susceptibility and perceived severity define perceived threat of the condition, the disease, or the outcome. So she might say, Girls like me can get pregnant, and it would really mess my life up if I got pregnant at 15. On the other side of the perceived susceptibility and perceived severity are what are the perceived benefits and what are the perceived barriers or costs. And together, this determine the cost-benefit analysis of whether an action is worth taking. So, she might say, if I insisted that my boyfriend use a condom correctly all the time, it would decrease my risk of getting pregnant. That's the perceived benefit. But my boyfriend would think I didn't trust him, and I don't know where to get condoms for free, and I would be embarrassed to go and buy them. Perceived barriers and costs. And so we don't necessarily always realize that we're weighing the perceived severity and susceptibility and benefits and barriers, but for our health decisions that we're making, we're doing these things often subconsciously or unconsciously. In addition to the perceived threats and perceived benefits, we have cues to action which come from outside of us. So those, again, other individuals in our lives. OMG, my best friend is pregnant and the school just sent out a text message reminding us where we can get condoms confidentially for free. So in this case, she's thinking about having sex. She's weighing out. She just said, well, I have no idea where I can get condoms for free. Oh, look, the school just reminded me where I can get them. That might influence her to make a decision to go get those condoms. And then, last but not least, certainly, is self-efficacy, which basically says, do you think you can do a particular behavior? So if you're thinking about using condoms, is this something she thinks she can actually have a conversation with her boyfriend about? So I think that if I talk to my boyfriend ahead of time, I could be consistent about using condoms every time, right? Versus somebody else who might say, I don't think I can even talk to him about this. I would be too embarrassed. It would be awful. He would hate me, etc. So how comfortable and how confident are you that you can do this behavior? And so put all together, you have your perceived threat plus your cost-benefit analysis, which are going to influence the likelihood of taking action, which are also influenced by these external cues to action and your own sense of self-efficacy. And so altogether, that is the health belief model. Another model is the theory of reasoned action or planned behavior, which is really the sum of beliefs about a given behavior. So, girls get pregnant or can get pregnant when they are 15. Lots of girls do, and getting pregnant at 15 would not be a very good thing because I might not be able to finish school or I would miss being able to go out with my friends. Condoms can prevent pregnancy, but it's hard to use them all the time. The pill prevents pregnancy, but it might make me gain weight, and I really don't want to gain weight. Right? So things that people might say, there's some of their beliefs about one behavior. They also have the sum of subjective norms. So what do people who are important to me think about this behavior, and how motivated am I to comply with their beliefs? So again, those external factors, those norms. So my boyfriend really hates condoms and thinks I don't trust him if I insist we use them. My mother, on the other hand, would throw me out of the house if I got pregnant. My best friend thinks I should go on the pill. Most of all, I love my boyfriend and I don't want to lose him. So in this case, this individual is trying to think about all the people, all of the norms in her life, and trying to balance them with what her own beliefs are. And whose opinion and whose beliefs are you motivated to comply with most are going to have an influence on your behavior. So in addition to your sum of the beliefs about the behavior and the sum of the subjective norms, we have perceived behavioral control, how much control you have over actually doing the behavior, and your perceived power. So behavioral control, it'll be really hard to make sure we use a condom all the time. But I can get condoms for free at my school from my favorite guidance counselor, and my health teacher taught us how to use them correctly. So I know I can get them for free. I have control over that, and I believe I know how to use them correctly. So behavioral control. And then perceived power is how much power of influence do you think you have to actually make the behavior stick? So all right, I'm going to talk to my boyfriend about using condoms all the time, and he really loves me, so I think I can convince him. That is the perceived power. And so if you put all of those behaviors together, or those concepts together, you take your sum of the beliefs about the behavior, the sum of your subjective norms, which together form your behavioral intentions, what you intend to do, and then you have your perceived power, your perceived behavioral control, and that's going to determine whether or not you use condom every single time, or at least once in this case. So that's the theory of reasoned action or planned behavior. And again, it's called, reasoned action and planned behavior because you're taking the time to think about your beliefs, think about your subjective norms, and really look at your behavioral control and your perceived power and how that influence your intentions. So we know that simply knowing something is healthy or unhealthy isn't enough. You have to intend to take the behavior. These things don't happen, believe it or not, by accident. We also have something called social cognitive theory. And again, this builds on the previous two theories insofar as it includes some of the other concepts. So something like self-efficacy. Can I do it? Do I believe that I can do it? An identification of goals. So what exactly is it that I want to achieve? Do I even know what those are? And what do you expect will happen if you take the action? Do you think that you will achieve your goal? So if you have a goal but you don't think you can achieve it, you're probably not going to work towards it. Social cognitive theory also brings in those interpersonal relationships a little bit more. And it introduces the concept of reciprocal determinism, right? The idea that behaviors are learned and reinforced by the interaction of the person, the behavior, and the environment. I do not need to. I'm sorry, I was about to jump ahead. So if I have a particular behavior, it may change the environment around me, which therefore changes my behavior a little bit more. It also takes into the account that we can learn from others. We do not have to do a particular behavior to see what the outcome would be. So if we think back to the girl who was thinking about having sex for the first time, and she said, "Oh my God, I just found out that my best friend got pregnant." Right? So that's it could happen to me. I don't have to test those waters. The classic example would be, I don't have to touch a hot stove to know that I can get burned. I can simply see somebody else put their hand in a hot stove, get burned, and know not to touch it. And that is called vicarious or social learning. So learning by observing the actions of others. And again, self-efficacy. So in order to perform behavior, people have to know what to do, how to do it, and most importantly, feel capable and confident that they can do it. Last but not least, at the individual level, we have what's called the stages of change, or the trans-theoretical model. What this says is that not everybody is ready to make a change at the same time, and people fall along a continuum. So we can have pre-contemplation. I'm not even thinking about it. You might not even be aware that there's something to think about, right? So, I've never even considered going to the gym. I didn't think that was for me. I didn't even realize I was at risk. I didn't even know there was a vaccine. That level. The next stage is contemplation. So now you're aware that there's an issue or there's a behavior and you're thinking about doing it. You're not quite ready to do it yet, but you're like, that's worth thinking about, I suppose. Wow, so there is a vaccine for HPV. I didn't even know that vaccine existed, or I'd heard about it, but I didn't realize it could protect me from cervical cancer. I didn't know what my risk for cervical cancer was. That's something to think about. The next step is preparation. So now that you know that there's a vaccine for HPV, you're going, well, but how do I get it? Like, do I have to ask my parents? Can I just go to the student health center? Where would I go? How much would it cost me? Can I afford it? So you're now thinking about how to plan to do it. You haven't quite gotten to the point of doing it yet. Action. I'm beginning to do something. I take the action, or you're in the process. And then the last stage is maintenance. So you're figuring out how to keep doing it. So if we go back to the, wanting to exercise, haven't even thought about it, not interested, not my thing, I don't like gyms. Oh, wait, but my friend just told me about this great gym where they feel really comfortable and they like it. Maybe it would be worth checking out. Well, where is it? How can I fit it into my day? Can I afford it? Preparation. Okay, I've gone to a class, I signed up, I'm now going. I started the process. How do I make sure that I can keep going, say 3 times a week, even through finals, even through the summer where I'm not on campus, in different situations? So how do you maintain that behavior? And while this seems like it's sort of a straight linear stages, right? So you go from pre-contemplation to contemplation to preparation, etc. It's a little bit more wiggly than that. So, you sort of go from pre-contemplation to contemplation. Now, once you know it's a problem, you can't really go back to not knowing it. But you might go from contemplation to preparation to action, maintenance, over to maintenance, back to action, back to preparation, back to contemplation. You sort of fall off the wagon. You go, I really should get back to that. And then you prepare again, and etc. So it wiggles and it moves, and it's not linear. But the key to this theory is that you can't expect people to jump from pre-contemplation to action or contemplation to action. You really need to move them, or pre-contemplation to preparation necessarily. And so if you're planning programs, it's important to know where people are in their stages of change. And then you can apply some of those other ideas of self-efficacy, cues to action, etc., to move people who are pre-contemplation to contemplation, those who are contemplation to preparation, those who are preparation to action, and a whole separate field is how do you help people who are taking the action maintain that behavior in the long term. So these behaviors and these theories can be used in conjunction with one another. If we think beyond the individual, though, we know the community level variables and concepts can also be applied to change behavior and improve health status. So we have our little individual, and they're happily living and they're making their choices, but they don't live in a vacuum. They've got all these other people. They've got their community, their family, and different social networks that influence their behavior. And in addition to those people, right, and within that, we are not actors in a vacuum. We are participants in a social and cultural environment. And within this environment, there are multiple influences on our health and health choices, such as education, occupation, income, wealth, housing options, neighborhood, and the effects of things like race and racism. And the interplay of these actions can either constrain or expand the choices that we make. And layered over that, we have our physical environment that we just talked about. Again, do we live in a neighborhood that has air pollution? Or do we live in neighborhoods that have a high amount of park space, which might influence whether we're more or less physically active? What type of food outlets are in our neighborhood? Do we have a full service grocery store? Not every community has one. And not everybody has access to a full service supermarket. Is there noise pollution? Is there overcrowding? These all affect the decisions that we make. So it's more complex than just one individual standing on their genetics making their decisions. And so, in other words, we have what's called the social ecological model. So this means that the entire burden of improved health or reducing risk should not be placed solely on the individual, but that responsibility must be shared between individuals and their families, between families and their communities, and between communities and their state, provincial, and national governments in order to be effective. As an individual, you can influence your social and cultural environment, as well as your physical environment, and those things in turn affect you, your behaviors, and your health. The arrows go in both directions. And so the goal of community level programs are to raise awareness and increase priority of a particular problem. Right? So, is it a problem for that community? Do they believe it's a problem? How big of a problem is it, and where does that problem lay in the context of the overall community and their needs? Help community make individual changes at the individual level, but also strengthen legal and economic support for those changes. And looking at, again, those broader models and looking at this sort of social ecological view of health, reinforce social norms that support healthy behaviors. And in order to do this, we can use things like health communication, where it's important to develop relevant, accurate, accessible, and understandable information. And this is built on theories which can predict and explain how and why people engage in particular behaviors. And again, this uses that social ecological perspective, looking at tailoring messages at the individual level. What stage of change, for example, are you at? Targeting messages that at the group level. So if we know a particular group has a particular social norm, how can we target a message to that community? Using things like social marketing, right? So media buys, ads, billboards, texting campaigns, social media. Using advocacy and social advocacy at the policy level. So how do you influence policy? How do you become engaged and active? And mass media. So this is your brand on drugs, or look at the ad council and the number of PSAs, so public service announcements, to try to change behavior. Community organizing. And this is really important because, as I said initially, public health is that connection between public and private. And so knowing where individuals stand, have an input, who are running for office, who are in office, are going to have an influence on the policies that they enact, which are going to have an influence on your behavior. And so there are steps in community organizing. One is development. So not everybody agrees, and you're never going to get a whole group to agree, but can you build consensus? Can you identify 2 or 3 key issues that you want to address, that we can all agree need to be addressed, and we all agree the direction that we need to go in? Do you have capacity? Are there enough people who are interested in working on this issue that you can have a voice and that you can affect change? And therefore, it really relies heavily on the community members. If you were coming in as an outsider into a community, you're not going to be successful in influencing change. You cannot come in with your outside view and think you can fix somebody else's community. First of all, that's not culturally competent to think that you have that capability or that you have a full depth of understanding of that community. What you want to do is work with the community, help them identify what their needs are, help them build the capacity, and really rely on them to drive forward the process. There's social planning, which stresses solving specific problems and relies on the experts. This is where you as a public health professional come into play. So you take these ideas and these issues that have been identified by the community, and you give your expert opinion on either the next steps or what has been done in other communities, or ideas for how to identify these problems, solve the problems using your public health knowledge. And then there's social action. So what are your concrete goals? What are your objectives? And what are the steps that you can take to address those changes? Or actually redress, in some cases, social injustices to solve problems. So some common characteristics of community organizing is empowerment. So very often, especially when we're talking about health disparities, which we'll be moving into, Um, there are communities that are disenfranchised and disempowered, and they feel like they cannot make a change. And so identifying ways that they can have power over the process, that they can have an influence on their communities and how they can make those changes is really an important first step. And once individuals feel empowered or enfranchised to make a change, you can start to build community capacity. You can get more and more people who want to work on that. And through that, you can increase participation in the social process and in the political process. There needs to be relevance, particularly around your issue selection. You can't identify things that aren't going to have a big impact or that aren't relevant to those individuals' lives. So again, as the public health professional, if you're coming into a community from the outside, you may have your ideas of what's important. They might have completely different ideas because what you're proposing might not be relevant. So, when I first started working in public health, I was working as a nutritionist in low-income communities. And part of what I was interested in doing is really teaching, right? So I was very knowledge driven, and I was doing community education. And what often we would find is we would be talking about fresh fruits and vegetables or how to get more protein in your diet, low cost proteins, and they would say, I don't have a refrigerator. I can't store these things. I can't store meats. Or we would work with food banks and food pantries that were giving out dry beans, which is great unless you don't have a stove and you have nowhere to cook it. And so the issues that we were trying to address were not relevant, right? We were talking about budgeting and they were talking about simply getting their children from point A to point B safely. And so looking holistically and really listening to the community to develop this idea of what is relevant, what are the issues that they need addressed. So another example is I was going to be working with food pantries and soup kitchens to do health education and nutrition education. And I went in and I had a whole plan that I wanted to enact, and I was going to help people, and we were going to work through community-based organizations, primarily churches, to increase fruit and vegetable consumption. And I walked in with my plan, and they said, that's really nice. What we need is to figure out how we can get food for our soup kitchens and our food banks, because we're having trouble accessing foods, commodity foods. And so, how do you do that? Well, I said, okay, well, if we're not going to do plan A, let's listen to what you need, plan B. And we worked with them to create a guidebook on how do you access commodity foods. So where do you go to get the foods that can be donated? What do you need? What are the guidelines, etc. So they could provide those services. Once that was in place, they were then able to take the next step. But we had to listen to them and listen to what their needs were. And then there's this idea of critical consciousness. Right? You have to have enough people in a community not only aware of the issue, most of them are, but also aware that they're empowered to make a change and that there is a critical capacity and people are working on this so that they can also feel like they can get involved and they can have the change. And when we think about how that happens, how you achieve that critical consciousness, we think of something often called diffusion of innovations theory. And this theory examines how new ideas, products, or behavior becomes the norm. And this theory deals with behavior change on all levels: individual, interpersonal, community, organization, and integrates related theories. The theory focuses on widespread behavior change, and health informations have yielded thousands of small-scale successes in behavior change. But how can this be done on a grand scale? How, for example, did vaccines and mass immunizations of children become routine? Well, diffusion of innovation theory provides a description of how such innovation spreads naturally through social networks and analyzes how to use diffusion networks to plan large-scale behavior change. And there are four main elements whether or not an innovation will succeed: the nature of the innovation itself, the kinds of communication channels available, the amount of time it takes to adopt a particular behavior, and the characteristics of the social system through which the innovation spreads. And diffusion takes time. The process of going through the various stages of change, from initial awareness to intention, to adoption to sustained change, may be gradual for both individuals and for organizations. And the funding for many promising programs or programs are prematurely evaluated and found wanting before the desired change has a chance to occur. So, because this takes a long time, we may be moving from awareness to intention, but not intention to adoption because we're evaluating here. And we haven't, and even once we adopt a new behavior, it's not necessarily going to show in terms of health outcomes immediately. That might also take time. And we are, a culture that likes quick changes. We want to see things happen. We are very impatient. And so, depending on where you evaluate your program, you may or may not be able to see the changes. And when we think about how innovations, how new things move through groups, the innovation is first spread by pioneering individuals who initiate or import it. Right? So you have those people who, when the new iPhone comes out or the next Xbox, whatever version it's going to be, are willing to stand in line overnight in the rain to get it. They have to have it right away. They like the new thing. Right? Once it gets through those pioneers or innovators who then start talking about it to their friends and now more and more on social media, it becomes a slightly larger group of early adopters, a category of local missionaries for spreading the diffusion process. And early adopters are key players in getting an innovation to the point at which enough individuals have adopted it that the innovation's further rate of adoption becomes self-sustaining. So you have your pioneers, you have your early adopters, then your later adopters, and eventually you get almost everybody, and then there are what are called the laggards. These are the people for whom they're never going to change, right? They still have flip phones, or the example I used to use is they still have rotary phones, which I don't think anybody has anymore. And they're not willing to change. And they're not going to change until they absolutely have to, until that flip phone is no longer offered by Verizon. And then they will move to the smartphone. And so there are going to be some people who you simply cannot reach, and that's the way it is. But the key for diffusion of innovations is really identifying who are your key stakeholders and who are the influencers, right? So we call them pioneers or innovators, but they're also the influencers. Who are the people in the group that can get other people to do something, right? They say, hey, this is the thing to be doing. And then their friends are willing to try it and so forth. And so the key of looking at all of these theories of behavior change, whether we're looking at it from the perspective of an individual and looking at the health behavior model or theory of reasoned action or planned behavior, if we're looking at how do we bring in that interpersonal with social cognitive theory or community change or policy, is that none of these things are quick and none of them are particularly easy. And so we need to be patient. And as we'll talk about more going forward, almost none of them rely on an individual making one behavior change or one decision to change their behavior. So we live in these broader environments that have an influence on how we think, what we have access to, both physically and financially, and what changes we can reasonably make. And so it really is that interplay between the individual and the broader community that's ultimately going to influence our health. And we'll continue to talk about this more as we move into conversations about health disparities, health equity, and social justice.